Thank you everyone for coming to another CNR event. Our title this time is How Can We Enhance Motor Learning in the Neuro-disability Across All Settings? And we've got 4 fabulous speakers for you today. And this is great. Because we've got 4 speakers, we're not going to be totally tight on time. So if there are questions, please do ask. I want it to be a really nice interactive session. I'm going to bring a mic around, so I won't push it in your face, but basically no wine, no question. If you don't ask any questions, there's no wine. But then after the event, we will obviously take our opportunity to enhance more collaboration and go into the foyer and do some networking as well. Okay, so our first speaker, any other questions before we start? So this is a one-off, first off for us, because we've got Ian, who's a podiatrist, which is fabulous. Come on down, as they say. And we want to welcome Ian, who's going to talk to us about encouraging positive neurophysiology adaptation in post-trauma feet and ankles, a 10-year exploration.
Firstly, thank you. I don't want to give too much information about myself. You want to listen to what we're going to say. I'm a podiatrist in private practice based in Brighton, so I managed to get here in time this evening. This is, if you wish, the summation in brief of the last 10 years. It began with a fluke in somebody's treatment, and then it spent the last 10 years trying to understand it. And I think I've reached a point where it needs to go into the psychology side of things. So that's where I am at the moment. So here we go. Essentially, we're talking about stiff feet, what we do with them, and how something's evolved in my practice over the last 10 years. This is an example of a lady, complex regional pain syndrome, post-trauma dystonia. She had a 3 years duration of this, post-amputation of toes 3 to 5, and she ended up then with toes 1 to 2 permanently dorsiflexed in the air and the ankle incapable of dorsiflexion because it was absolutely rigid or plantar flexion. This is the fluke, all right? She asked me to do something. I said, I can't do anything. Let me try this. And within a few minutes, both toes just dropped on the ground. I had a very interesting expletive erupt from my mouth, as did she, but this is where it began. This is where it began, and the carpet is atrocious, I know, all right? Example 2, again, post-trauma dystonia, as I understand it, okay, and some of the things I've read, 3 years duration, severe injury to the big toe, get rid of the terminology, and yet no CRPS or anything like that. He didn't have any treatment for the injury to the big toe. I had to go at something, and what we see there is basically all the toes that were stuck in the air that you couldn't physically push down or drop down immediately. Again, from a very simple something that I didn't understand. This is a slightly different one. This is a combination of therapies that after several years, this arrived on my doorstep. Top side of slide is somebody who has got post-trauma dystonia, complex regional pain syndrome, 9 years duration, spent 9 years walking in an air cast boot. And there's a real psychology behind that, which I won't go into at the moment. What you're seeing on the bottom there is each of the stance phases there, the feet are in a normal position. That occurred with 3 treatment sessions over 12 weeks. And it was a mixture of various things into there I can always talk about. Each of those people has still got the benefits of that. The only trouble for this chap here is having had lots of surgery on his feet and plates and screws, they are now creating problems for him, but he's still walking, as it were, with a foot fully on the floor. And this is a normal situation, if you wish, with somebody with peroneal tendinitis. You'll see on the slide on your left that the midfoot is not in ground contact, and yet on the right slide it is. And again, by this point, I was fairly sure what I was aiming for and heading for. That took approximately 2 minutes to change. And it carried on being like that. Okay, and this is why it's like, started with the fluke, I'm hoping it's going further and further. So what I've arrived at is there are 3 things we essentially need to have an ability to maybe make those changes, and I accept placebo and everything else within that. The first one is we need the presence of a pertinent mechanoreceptor. Okay, and in this instance we're talking the Ruffini receptor. All right, but bear in mind, although we might say we're going to stimulate that one, you can't do it in isolation, so there'll be other things going on as well. But we want a pertinent mechanoreceptor. And why that one's relevant is that it responds to slow stretch. Okay? And from what we understand from my reading around, it may encourage a downregulation of the sympathetic nervous system. Okay? Happy to be proved wrong on this one. We need architectural placement of those receptors. Okay, it's not good just having them there. They need to be in a place where we can stimulate them and perhaps target something. And then we also need an advantageous structure that surrounds them, and that's where I've arrived at. So I'll work through this one. So we need the presence and the architectural advantage. Okay, this is a slide from Carlos Stecco's book on, sorry, I've gone back to it, sorry about that, on the functional atlas of the fascial system. What you're seeing here is a cutaneous area of the foot, as I'm highlighting there. So electrophysiological studies imply raphenes are present within the cutaneous tissues in that region. I use the word imply. We don't necessarily have the histological evidence for that. Okay? They're there within the foot sole, they're there within the plantar medial arch, but they are few within the foot and within the hand anyway. But they have a very wide receptor field. Okay, so I don't have to go hunting for it. It's there, it's a larger field, can respond. Okay? Importantly, can a stimulus of a single receptor make a difference? Well, yes it can. Bent et al. On that reference there have demonstrated a single receptor on the dorsum of the foot that was stimulated, modulated muscle function in the biceps and triceps. Get your head around that one. That's a remarkable thing, isn't it? So it's potentially there. All right. What we then move on to is this, where we're looking at histological studies. So we do know for a fact that histological studies have demonstrated the raphena corpuscle lives in the medial and the lateral bands of the plantar fascia. It lives within the retinacular of the tissues there as well, and also lives within the surfaces of those muscles around that area. So we actually suddenly have a large area of receptivity that we might be able to stimulate. And advantageous structures, here's this. You see the three lines? They represent the skin, superficial fascia, deep fascia, in that layering order. You'll see they're wider at the top, because if you look at your legs, you'll discover that it's quite fatty around as it comes down there, all right? But as we narrow towards the ankle and we come down towards this area of the portopedis of the foot, they become almost merged together, okay? Not quite. So the skin, superficial fascia, deep fascia, insert into the deep fascia in that area of the foot. You can't move one without actually moving all the others. You can have a go at yourself if you want. If you put your fingers on that part of your ankle later on, try and slide the skin, it won't move. So any pressure you put on there is a stimulus pressure. Okay, right here. That makes some sense? Got it right here. Interestingly also, the plantar fascia and the skin at this point here are pretty well inseparable, but apart from some adipose tissue. But the ligaments of the plantar fascia, ligaments of the skin go directly into the plantar fascia, so you can't slide. If you move anything there, you're moving that area. So application of a stimulus to raphena receptors can be applied in this region, and this is what I think I do. Usually, based on the last 10 years, we observe physiological changes in a single session, usually within a couple of minutes. There are always exceptions to a rule, okay? I'm just being very brief. So what might be a neurophysiological cascade from this stimulus? And I use that term because in manual therapy, it's understood that manual therapy creates the stimulus that generates a neurophysiological cascade of events, and that's what brings the change. But you need that mechanical stimulus, and that's Bielewski 2009. So what might be a stimulus? And this, you can have a laugh at this because I really don't know if this is true or not. So there we have our picture. We have our foot that's got a lot of increased tone about it. And we apply our stimulus to the cutaneous and the fascial tissues. And they undergo a sustained deformation, elongation, and angular change. Now, the value of this receptor is it keeps stimulated all the time you're doing it. It doesn't switch on and off until you remove your hand. Okay? That stimulation through those there, that also is what you might call the fascial interstitial receptors there as well, giving recognition of other neural elements there. It initiates an action potential, which then goes up a particular pathway, which you'll know more about than me. Terminates the dorsal horn and spinal cord, again, you'll know more than me. And then we get up to this area where it gets it's relayed to the thalamus, okay? And we begin to get this interaction, this conversation between the thalamus and the cortex. I don't know, you're the guys that know that, okay? That's okay, that's pretty good. It's like, what happens next? Okay, why does that change? Why do we suddenly get a down-regulation and what's going on? Here's a thought. It's proposed by some people that we see an increased vagal nerve activity. I actually don't really understand what the vagal nerve is, all right? So can't correct me. However, it's also suggested it downregulates the sympathetic nervous system, okay? And what we might see, autonomic nervous system changes, and from that point, I am assuming that we get an efferent command. Something comes from the boss at the top and tells something what to do at the bottom. That's my understanding of it. Okay, so what might happen then, okay? If we throw into this some additional changes that are proposed, okay, hypothalamic frontal lobe activity, okay, may quieten increased emotional state, contributing to lowering of muscle tone, reducing perhaps anxiety-based guarding. And the one thing I've come to recognise from this, but also lots of other people that don't have these conditions, but just straightforward, if you wish, injury conditions post a bad ankle sprain, is they are guarded, massively guarded. Okay, so we're seeing that reducing. This really says, although we've got a mechanical stimulus and there's a very real physiological issue, it's the psychological emotional change that is the cascade. I hope that makes some sense to you. We now get this normalised tonus. That's what I think it arrives at. And then practically what does this mean? Well, the outcome for me with patients is this: immediate within session physiological change. Now, in terms of therapeutic alliance, that's phenomenal. You can't actually have a better win than get an immediate change, physiological change, to build into them the drive to carry on to do their exercise and things. Patient perceived ground contact seems to be an increased measure. People talk about going over their foot easier, more sensation on the bottom. Well, that's a possibility, and you'd use a pressure mat to measure that. However, I think you could also argue that if the foot's been very stiff, muscle spindle activation and sensitivity is being reduced. They're not getting the full neurofeedback from it. Relax those muscles off, you then get muscle spindle activation more readily doing what it should do, which is that neurofeedback. So actually it's muscle spindle activation that maybe they're sensing more than anything else. Plus, as you saw with the guy, his foot went over as well. All right then. So I think we also find improved muscle engagement, which comes back to the spindles. It might come across as restored power or strength or coordination. Practically, what does it move us towards? Well, I think it restores proprioceptive capacity. Okay, and I think what we're looking at is a normalising of muscle function for that individual, and that's it. There we go.
Thank you, Ian.
Right.
Great talk on, well, ankle and
Feet.
treatment. Yeah, so I
Yeah.
think there's a lot of questions that we might want to unpick there. if
The
that's
wine.
Okay.
We want the wine.
Any particular questions for Ian? Go, Fran. You might need to-
Tell me who you are and what you do, because I haven't got a clue if I can answer this question or not. You might be better. Go on.
I'm Fran Brander. I'm a physio here at the National
Oh, God. Yeah, go on.
in rehab. In rehab, so I treat people
Psychological safety.
post-stroke, post-head injury, that kind of thing. And I'm totally blown away that one session you can change somebody whose ankle and foot was in a sustained posture for so long. What do you actually do? Are you
I'm
rubbing
going to
that
summarise 10 years for you. All right. What's the most difficult lesson I have had to learn in 10 years? It's simple: to do almost nothing. That's been the most difficult thing to learn, to do almost nothing. So essentially I'm working in the area where the portopedis is there, and that's the structure and that's the receptive area. The level of pressure, once I've taken the skin into a certain level of slight tension, the level of pressure is about 4 to 5 grams, nothing more. And patients will often say they can't feel me doing anything. Now that could be just absolute blind placebo and trickery, but actually my fingers are moving. All right, so I'm doing something. And all you just do is just carry on working that and just see if the foot starts to ease off. The guy with the 9-year one, I've sweated the most with him. I don't want to go into all his other comorbidities. It wouldn't be appropriate here. But I did sweat the most because it wouldn't be unreasonable to say he was facing potential amputation. And so we were able to work with him. He first came to see me for one issue. He drove 3.5 hours to see me for one issue. I said, well, I can't help that. and he said something like I said before, and then I had a chat with him, and I said, look, I don't know if I can help this foot, but this is what I'm doing these days. It's fair to say I also work with connective tissue on this area as well. And then he came back 2 weeks later, and we started, and that was 3 treatment sessions over 12 weeks, which involved listening, reflecting, teaching him how to walk with that foot again, some simple exercises at home. The big win was that he came back. That was the big win. And he allowed us to work together because, I didn't really do anything. I did a stimulus. He did the rest. I'd love to kind of say...
How long would your treatment be, like dosage, would you be?
In terms in general, about 2 minutes.
2 minutes? Okay.
Yeah, about 4 to 5 grams. Okay. I'm fully accepting, all right, I could be completely wrong in this, all right? Okay, yes, sir.
Oh, Mike.
I'm happy to learn.
Hi, I'm Nick Ward. I'm a neurologist here at Queen Square. So how common is this condition, and what disease states do you normally see it in? So when you say post-traumatic, you're talking about local...
Sorry, I'm slightly deaf, even with my hearing aids. Could you just speak a little bit louder for me? Yeah, sorry.
So how common is this condition, and what disease states do you see it in? And just following up from that, so have you shown us a single case, or have you shown us multiple cases? How many people have you done this in?
So the 10 years is a mixture of people like this. This is actually relatively rare, this kind of condition. I think so. I don't know from your point of view as physios, but post-trauma dystonia is considered to be relatively rare. So that's been part of what I've been dealing with. I've got a few other cases like that I can show you. But actually the muscle guarding component of that isn't so rare, and is far more common in standard injuries from post-ankle sprains even 30 years ago, where they've had the physio, osteo, even me doing mobility and manipulations in the past. You get somewhere where I've had to rethink a lot, and one of the reasons why I stopped teaching the mobilisations courses that I used to teach is that I think there's a simpler way, and that's why I stopped back from doing that and started going down this road. So that condition, the big conditions, are rare. Ankle injuries, other kinds of post-surgery injuries, guarding is absolutely wrapped up in that. And so that's done pretty well on a daily basis in my clinic. I don't know if that helps. But this is post-trauma. It's not an upper motor neuron. It's not an upper. It's more of an incident that's happened, and that's why it becomes localized.
I'm just wondering if you're collecting data on this. Are you publishing data?
Collecting data.
Right. Okay. So that's my next challenge. This is all my own work for the last 10 years, and the question is, can I be bothered now to take it? I'm 60. I'm not being funny, but I'm 67, so I'm not. It's like how much more of my life do I kind of keep on doing that, and what have you. But I think there's several types of data. One is maybe pressure mat. The other one is getting power against resistance changes. And one of the things that becomes very clear when you do this is that the physios here will correct me on this, I'm sure. But if you're doing a power against resistance and you've got a system that you do it, and people are kind of poor and low on that, if they're like double and treble what they were when you first saw you at the end of that first session, that's a significant win in terms of muscle spindle activation and capacity, that neuro element. It all needs to be looked at, but I think the big thing, if I don't mind, is maybe what we also want is MRIs of the brain when it's being done to see what actually is going on, what's being released in those areas.
I think just for time, we just want to say a big thank you to Ian for your coming to join us all the way from Brighton.
That's all right, very welcome.
You.
Yeah, thank you.
So next up, I think some of you might know Sarah Sparks. I know she's very famous in the neuro world, and she's developed some amazing work with legs, and it's a great opportunity to see Sarah Sparks today, if I could just open it up properly. And there you go. So she's a highly specialist physiotherapist. Welcome. Thank you very much.
Nice to be back. And tonight I'm going to just talk about flying the flag for the third sector, but really trying to hone in on how tele-rehab can enhance motor learning. And it's a really good platform for us all to kind of start to think about within our practice. So One of the big things that we do at the charity is we now run hybrid exercise groups. So we run face-to-face exercise groups across London, and also we run a variety of groups across the platform utilising Zoom. And part of the charity, we really identified that to get behaviour change and to get motor learning, you need education and buy-in and professional support. So we run a weekly Neuro Cafe session, which has links with kind of other charities, organisations, expert speakers who come and deliver some kind of education. And then we have some drop-in sessions for peer support and talk about behaviour change. And the pandemic showed lots of us, and some great work published from the Enroll guys from here and up in Lancashire about how remote rehab works from a telehealth point of view. And from a charity importance, it's really viable and it's very cost effective. So we need to be upskilling as therapists in delivering that model across kind of our work platforms. And the nice thing from the charity point of view, and it really ties in with the new stroke guidelines, is that from our point of view, we're not time restricted. So people can come to the face-to-face groups and the online groups on their needs, on their goals and their terms, and there's not a cut-off, so they don't have to be exited after 6 weeks, 12 weeks. So I've got the luxury of looking at a little case study. One of our patients who had a stroke actually in a telehealth meeting. So she had a stroke online in her business meeting, and she came to us being told that her arm wasn't going to do very well for her. She was 40. And we are really going to just look at her journey over the last kind of 3 years from the charity. When we went to design some upper limb groups and some exercise groups across the whole charity, there wasn't very much out there about how to run exercise groups online, how you construct a group for neuropopulations. And I think these two papers, I just wanted to talk about. If you haven't seen them, just really go and look at them. James McLaughlin down in Australia has written this really nice paper with a good simple infographic, which I love. It's about 10 guiding principles for movement training, and really thinking about making sure that in your exercise prescription, you're thinking about your role as a coach, but also those things about how you give your feedback. We all talk too much, and we do that worse on tele-rehab because you don't get that nice kind of interaction as much. But are you including your kind of knowledge of performance, knowledge of results in your exercise prescription and your design of your intervention? Are you thinking about physical capacity? And yeah, his paper really summarised it nicely. And then there was one from 2019 from Mayer who looked at very similar principles to James, but it's much more about motor learning and brain plasticity mechanisms. So there's a bit of a science behind what we should be doing in exercise prescription in what we've tried to create at the charity, really. And it's not perfect. You'll come along to exercise groups and you'll see the top half of someone's body and you don't get to see their legs because they can't work out their setup. But you've got to adapt to that as well, really. So we've set a range of exercise groups that really are trying to promote an active neuro community, and we want to see our participants as athletes. We've really taken on that board from Neurofit and Nikki Penny about how we should train people hard, and people want to work hard and they want to do that online as well. So we have some specific upper limb groups. We have some classes where people come with their carers or their friends, where they're called in a RISE class, which is thinking about giving some therapeutic education to other organisations, kind of their carer, and to upskill them to go away from the class to be confident to do exercising. So we're really thinking a bit more about dosage. I'm not going to go through the range of classes because I think the case study is what we want to focus on. But so this lady was a 42-year-old female, had her stroke in April 2020. So obviously had very limited input in a London hospital for rehab. We were at the height of the pandemic and she was wished out pretty quickly. Lived alone, all of her family live in America. You can understand what her mood's been like. And she's told that actually your hand's not going to do very well because you can't tap your index finger and you're not going to get very good recovery. So she came in a really low mood to us, but she had quite a good functioning arm. So that was our big thing to start off by changing her mindset and her emotional connection with her arm, and also thinking about her as a whole person, really working on being able to get her core stronger, get her her walking was pretty poor and she was really isolated because of her fear around the pandemic. So there's lots of things to unpick, which we haven't really got time to go through massively today. But I think the luxury of just presenting someone who we've seen for a long period is to see how her goals evolved when she started to see that she was making change. She started to see potential, and she got loads from other people in the group. And I think you can't really move away from motor learning by seeing people in the group enhance their function, and that increases her participation and motivation. So she's now kind of come on to thinking about her goals where she's actually got she wants to be able to hug people. That's a big one for me. I love it. She wants to be able to do her hair, which is very important for her self-image, and to be able to sign her name and write, and she wants to be able to write a book. So big things that really need a functioning hand. So obviously we referred her when the upper limb programme opened to come here for 3 weeks, so I'll just get that in. But she worked really hard in our online groups and has progressed significantly with task-specific training, lots of functional repetition. She's used the TRIO programme from New Zealand as a kind of self-management thing, as well as GRASP, and she's done lots of videos and recordings to try and get her dosage high. So this isn't just about what she does with us as a charity, but it's about the education that she's gained from having a physio run those groups on a weekly basis. So yes, she could have done some of that stuff following YouTube exercises, but the behaviour change and the motor learning came from the group dynamics, but also the education she got from the class itself. I'm probably always seen as a bit turquoise in my physio-like thing, so I would be very keen on not doing all impairment-based training in a group. So we do lots of functional task practice that is given by the participants, which is key really for her intervention. These are her overall outcome measures, and they run from 2020 up into 2023, just because we haven't done the 2024 ones yet. But you can see she's got stronger, her balance has improved, and then in terms of her upper limb function, I've done the table the other way round, but you can see that her ARMA score has gone from 14 to 4 and from 32 to 17. So those smaller numbers are obviously meaning she's got more function, which is super important in terms of her quality of life. And that's reflected in her quality of life scores. We just do the general EQ, 5D, 5L. And obviously everyone's mood and kind of stuff goes up and down, so it's not linear. She does start to improve, and then she has a bit of a blip in 23 to 24, but that's life in general. So that's an overall measure that tells you that she's doing well. She smashed her goals. She comes to 5 sessions a week with us online. She lives near a face-to-face group, but she actually prefers online, and that's interesting from a 40-year-old. And she says that the charity has been her lifeline. I have learned so much from the amazing physios and the participants. I have made friends for life. And I think that can't be taken away from our face-to-face groups or the online groups. It's about the community. And adherence to exercise for 4 years, doing some of that stuff is pretty boring. But the commitment she's done, I think, is because of the community she's created. And we heard lots in the Olympics about happy athletes and successful athletes, and we really try and embed that into our participants. If you're feeling good and you're motivated, and we're thinking about that behaviour change and the taxonomy criteria is really key. So big thanks to all the team and the participants, and yeah, that's me done.
So up next we have Rob and Eva, who've come all the way from the Wellington, that's not that far away. But I want to thank you. You've got occupational therapists and physiotherapists talking about a novel hands-on tech circuit-based therapy in an inpatient setting. Welcome, thank you.
Okay, thank you to CNR for inviting us to talk this evening. Rob and I, we are going to present a service improvement project that we carried out in our rehab unit and that led to the implementation of a technology-based upper limb rehab group that we called Hands-on Tech. So we know that following a stroke, there is a large percentage of patients who experience loss of upper limb function. Literature suggests that therapy interventions are beneficial if they involve a high dose of practice. And this is more relevant if we want to create meaningful changes on chronic stroke patients. And despite of having strong recommendations for high dose and high intensity upper limb rehab, implementing this in practice continues to be a challenge. there is also a growing role for technology to aid delivering intensive upper limb programs. However, how best to deliver them remains under-researched. Finally, some studies have determined that a large percentage of practice can be performed as semi-supervised practice in inpatient settings, and this doesn't actually compromise the amount of time the patients are engaged in active therapy, neither their safety. So we started our service improvement project by reviewing our current practice. We audited some notes and we observed some one-to-one non-technology based OT and physio sessions, which highlighted very little time dedicated to upper limb rehab, as an average 37% of active time for OT sessions. This was in line with many studies reporting that less than half of a therapy session is actually spent in active upper limb practice. We also completed some patient surveys and found a recurrent theme of lack of opportunity for upper limb practice outside of some one-to-one OT sessions. We used some service improvement tools like SWOT analysis, driver's diagram, and we created a TDR checklist to describe the new intervention that we proposed. And Rob and I will now talk about our proposal. So we propose a 90 minutes technology semi-supervised circuit-based upper limb therapy group, which we run 5 days a week, and we call hands-on tech. The treating OT attends the first session to decide on the goals, the priorities for the use of technology, and whether the focus is going to be more proximal, distal, or whole arm treatment. The group is scheduled for 90 minutes, and we aim to deliver 60 minutes time on task. It is circuit-based, so the patients will rotate between 2 to 3 technology stations during that time. We aim to provide semi-supervised practice with a 1 to 3 paradigm, and we encourage the participation of relatives or carers, and we repeat outcomes every 3 weeks.
So in the first instance, we wanted to examine the feasibility of our hands-on tech group, and with that we had a number of key questions. So we wanted to know, could we get enough patients into our group from a recruitment perspective? We also wanted to know whether patients can tolerate 90 minutes of tech-based upper limb therapy 5 times a week. And alongside that, we also wanted to look at the semi-supervised practice and whether a 1 to 3 staff to patient ratio was achievable. Alongside this, we looked at a couple of core outcome measures, so the Fugl-Meyer upper extremity from an impairment perspective and the ARMA activity scale there, looking at sort of active and passive function. Our secondary outcomes, we also wanted to track and actually get an idea about, during the exercise group, how much time was actually spent completing active practice of upper limb rehab, and that was mainly captured through the technology devices that we were using, so we could kind of record some of that data. Alongside that, we wanted to know how easy the technology was for staff to use, but also for our patients to use, and we used a scale to examine that element. And then finally, we completed some movement analysis, so we videoed 1 or 2 core tasks, looking at sort of reach and grasp to look at those aspects. Our patients, so for the 3-week pilot, we recruited stroke patients at any time point post-injury. They needed to be able to follow 2-stage commands, and then they also needed to have some proximal activity at their shoulder and or distal flickers of movement at the hand or the wrist. Those patients with severe spasticity or pain at the shoulder limiting sort of participation, alongside those patients with dense weakness, absent movement, were excluded from the group, but they were managed in our other pathways. So, just to talk through some of the results, but we had 5 stroke patients that attended the group during the 3-week pilot. These patients were, 1 was an acute patient, acute stroke patient, 3 were subacute, and 1 was chronic. And our patients varied in age, so we had 1 39-year-old and 1 84-year-old actually. And that latter gentleman was one of the sort of key motivators within the group. As you can see there by the Fugl-Meyer sort of mean score of 23, our patients were at a moderate level of impairment from an upper limb perspective. Out of a possible sort of 75 sessions during the 3-week pilot, we only had 4 sessions that weren't attended, and often that was due to a clash with x-rays or scans. This is a sort of inpatient facility. In terms of the mean time on task, so the actual time spent actively completing upper limb rehab during that 90-minute session, we were hitting 41 minutes. And actually, when we looked at some of that data and we looked back to some of our auditing of our usual care, that actually equated to a sort of 240% increase in active time compared to our at best OT sort of one-to-one session. We could deliver the group safely. We only had a couple of minor adverse events. They were mainly related to fatigue, with 1 or 2 patients finishing slightly earlier at the end of the 90-minute session. But it's worth bearing in mind these patients are receiving 5 to 6 hours of MDT therapy a day as well as part of their program. This is just one component. And then obviously it's a short study and a small sort of sample size, but we did see some signal change. So we saw a meaningful change from a Fugl-Mar perspective, nearly sort of 8 points. And then from the ARMA section A and section B, some good changes there showing that actually these patients were finding it easier to care for their upper limb. And actually they found using their upper limb in day-to-day tasks easier too. The main sort of challenge we found, I think, as part of the group and subsequently kind of reviewing that, is the 1 to 3 paradigm. So 1 staff member to 3 patients was challenging. Reflecting on that and again looking at some of the information, we found that we achieved more consistently a sort of 2 to 3 paradigm as well. So just to conclude, I suppose our sort of key questions were that we were able to recruit enough patients to our group. Patients could tolerate 90 minutes of tech-based sessions. Our therapists and patients could get to grips with utilising the technology. And as I said, whilst a sort of 1 to 3 paradigm was challenging, we were able to work at a sort of 2 to 3 level. There were some good changes in our sort of core outcome measures, and obviously we need to kind of look at this and have continued to look at this over the recent months in a sort of larger cohort of patients as well. Thank you for your time, and any questions?
Thank you, Robin. That's very good. Yeah, great. I'm sure there's lots of questions. Sarah, you go first.
Thanks, that's really interesting. So can you just break down from your aim was 90 minutes to keep them kind of active and you got to 41. What did the kind of analysis show that you were doing in the rest of the 40 other minutes that they weren't active?
So our aim was 60 minutes time on task, but it was a 90-minute session as well. So a lot of that was still, so we had 2 to 3 stations, most patients were moving between, so there was still some setup time. I think because we had a dedicated group, the devices were there, ready in their different stations, that helped. Yeah. And it was more efficient than a sort of traditional one-to-one OT session. So I think it was a mixture of those elements and rest periods as well for patients.
And then obviously the time to take the patients from the wards to the gym, the normal kind of transit time. Some patients not bang on time ready for the sessions.
Hi, I'm Gian Paolo from the Helix Center at Imperial College. Just wondering if you could give a little bit more details about the types of technologies that you were using and if there were some that lend themselves better to what you wanted to achieve than others.
Yeah, so I mean, tech-wise, we've got a range of devices, and at that first session, as Eva mentioned, we'd work with the treating therapist to determine, are we really looking at proximal activity, and then we might utilise something like the Armio device. If we're looking at more sort of distal function and sort of technology for that, we have like a gripper ball, a neuroball. We would still use like FES, so even like a simple NeuroTrack device, which is 90, 100 pounds, we would be facilitating patients to be doing wrist and finger extension programs. And then subsequently since then, we've been evaluating other technology. So from sort of mind motion, there's some really good upper limb devices that we've trialled.
And some VR, normal, the MetaQuest Google glasses with a VR software that we have.
It's part of the Tyromotion with the virtual reality.
Yeah, it's not Tyromotion, it's another one, but
Okay, similar to that, for
So
reach and grasp.
Different exercises, different activities.
Okay.
But we're working with Brunel University that was sort of developing this app at
Ulster.
that time. Oh, Ulster.
Ulster,
Sorry,
yeah.
Ulster.
Yeah.
Fran, question.
I was interested that you were struggling with the 1 to 3
Yeah.
staff to patient. Is that because of the time for setup, or is that because you were worried about quality of movement, so you were kind of supervising them and keeping them on task, or what do you
I
think
think-
was the reason behind that? And going forwards, do you think that there's anything you could do to reduce,
I
get
think,
to the 1?
yeah, I think both aspects in some regards. I think obviously Ava and I were supporting the group initially, and then we had some of our assistants coming in supporting it too. I think it's quite a skill to be able to deliver semi-supervised practice. I think often we feel that our assistants can just sort of pick that up, but actually for experienced clinicians to kind of hold in your head 3, 4, 5 different patients, move around, make sure that their exercises are sufficiently challenging, they're progressive, the feedback they're getting. That's a lot of skill set that we're asking. So I think it's a still under-researched area. In our practice, we found we could kind of hit that sort of 2 to 3 paradigm. We had it's only 5 patients, and we had 1 or 2 patients that scored quite low sort of Fugl-Meyer scores. So those patients did need a bit more one-to-one and a bit more setup time. So, yeah.
Yeah, I think we'd echo that on our Upper Limb programme. When we have some staffing issues, if you're doing 3 to 1 or 2 to 1, still that's quite challenging clinically. Again, for the same reasons about clinical reasoning, about adapting, reducing compensation, quality of movement. It's really hard.
Especially if you're setting up tech.
Exactly, tech is really hard.
The more able they are,
Yeah.
I guess the easier it is, because they can get
Yeah, and we have the tech stations like set up before the class, so they're ready to go.
And also the cognitive aspects, many of our patients, although they have sufficient cognitive ability to engage with the tech, they still need quite a lot of one-to-one specific prompts and things like that, it's quite difficult to let them totally unattended doing it.
Nick, you have a question?
So you've done 5 patients now. Are you carrying on, or have you stopped?
No, so this was towards the start of the year, earlier this year, from a pilot perspective. So we've carried on with the group, and then since then we've tweaked it a little bit, so we're doing more sort of 2 to 3 paradigm. The other thing we've tried to embed is a bit more behaviour change. So we wanted to try and get our patients continuing their practice, whether it's FES or some of these other devices, outside of our sessions. So we already had goal setting as one component of behaviour change, but we've actually got patients monitoring, I suppose, their, what do you call it?
Practice,
their performance. And we've looked at that in different ways, because some patients, do respond to reps and more reps, 100 reps, 1,000 reps, all these sort of concepts. Whereas other patients have been keen to have diaries or take videos. So I think we have to bear that in mind when we're trying to look at behaviour change, that it needs to be individualised to our patients. And I suppose that's one element that we're still looking at the moment, and how we best facilitate that.
But you are currently still doing it.
Yeah, we're still doing that.
And then
we looked at 1 or 2 other technology devices and how they sort of sit with our group and the rest of our programme as well since then.
So, if you're going to carry on collecting data, because those patients were quite early, weren't they? They were just after 3 months post-stroke, so they're in that kind
we
of
just
early
had one sort of chronic patient.
Potential for spontaneous recovery. So some of your 7.8 points in the Fugl-Meyer is kind of
spontaneous.
It's just kind of spontaneous recovery. So you probably do need some kind of control group if you're going to assess the impact of this intervention in early patients.
Fran, you want one more question here?
I've got another question. Sorry.
I've got another question.
I know. I'll be very quick.
We've got 4 minutes.
So a lot of these technologies obviously work at an impairment-based level, and so they don't necessarily carry over into functional practice. But I wondered whether you'd noticed any change in kind of therapy time on upper limb rehab as a consequence of patients having kind of greater exposure to upper limb stuff, and then wanting to put their gains into more functional tasks rather than just worrying about walking.
Yeah, I think so. I think definitely patients valued this sort of protected time. They knew each day they've got an hour and a half to work on their upper limb. And when we audited our practice, we weren't achieving that. You know, at best we were giving 17 minutes of upper limb therapy a day.
I'm asking, I guess, outside of that 90 minutes, whether that then has an impact on.
Yeah, I guess.
Yeah.
Yeah, I guess that obviously the OTs and the treating team, they know that a big bulk of the impairment-based upper limb therapy is going to be done within the group, so they can focus more their therapy sessions in more their kind of functional ADL activity-based type of practice. And as Rob has said, we have noticed, many patients just subjectively reporting that they are more encouraged to use the arm more because they see that they can use it even if it's with technology. We have some patients even buying their own rep counters because they wanted to continue doing that outside therapy, and it's just motivating seeing that, okay, I can move my arm even if it's with technology, and subjectively we have seen that.
Okay.
And I think from a research perspective, there's more and more evidence around these sort of composite programs where you're using elements of technology from an impairment perspective alongside your functional task practice, which for some of these patients, they wouldn't have been at a level to do that functional task practice.
Okay, great. Thank you very much indeed.